Good morning, good afternoon. Thank you for joining us. I am Lindsay Denny from Global Water 2020. We are a WASH advocacy and facilitation group based in Washington, D.C. And we are here to join CDC and Makerere University talking about local production of alcohol-based hand rub for health facilities, a practical discussion on improving hand hygiene among health workers. So I thank you all for being here with us today. Exciting to have one final webinar of 2019 and very excited to hear from these two groups about the work that they are doing in Uganda. So as a bit of background, we'll be hearing from the two on their implementation, scale up, and evaluation of local production of alcohol-based hand sanitizer for healthcare facilities in Uganda. And the primary objective is to hear the practical aspects of local district level production. We plan to produce an FAQ document, a frequently asked questions document, following this webinar for you all. So as a bit of an introduction, we have two groups here. Dr. Mohamed Lamorde is the program director for the Global Health Security Program at the Infectious Disease Institute at Makerere University. And he is joined by Maureen Kasende, project officer for the Global Health Security Project. And then from the US Centers for Disease Control and Prevention on the Waterborne Disease Prevention Branch, we have Dr. Matthew Lauziere and Dr. David Berendez, who are both epidemiologists. So I will hand it over to you all to begin our presentation. Thank you.
Thank you very much, Lindsay. This is Mohammed. I'm really pleased to have the opportunity to give this talk. The IDI, Infectious Disease Institute, we work in partnership with the Centers for Disease Control and Prevention to support global health security work in Uganda. And this work that we're presenting today really falls under that cooperation. And so the outline for the talk today, I'll give a little background as to what really inspired our work in this area, focusing really on our experience at IDI with alcohol-based hand rub. There'll be a small discussion about facility-based versus district-based production. And Maureen here is going to talk about alcohol-based hand rub production, the facilities we need, the requirements, supplies and procurement, intervention. Hand hygiene is a critical intervention for prevention of healthcare-associated infections. But when we look at hand hygiene compliance, that's the number of times people actually perform hand hygiene versus the opportunities they've had to do so. We find out that we do very poorly. And so, for example, in national surveys that were conducted in Uganda, looking at regional referral hospitals, and regional referral hospitals would really be, just slightly above a secondary level of care. We found very low rates of hand hygiene compliance, so about 21% in 2018, but increasing slightly to 30% in 2019. And there are barriers to hand hygiene compliance. One of them is really that you don't necessarily have sufficient alcohol-based hand rubbing facilities, mainly driven by the cost. So a liter in Uganda could go for nearly $8 to $10. And many hospitals have a fixed budget and they would like to prioritize what request with that budget. And when they look at the cost of the alcohol-based hand rub, they tend to deprioritize it. And so the facilities have to rely on soap and water most of the time. But when you go to some wards, you'd find that even the sinks have been taken away from within the wards. Sometimes people get sick and vomiting and you don't have enough help staff to do the cleaning regularly. And so what happens during a ward round is that the healthcare worker has to go from back to the end of the ward to wash their hands and then come back again. And so you don't really have the incentive to clean your hands, at the 5 moments that are recommended. Some health workers may have a perception that alcohol may affect their hands and cause irritation. And so there are some perceptions around its use that might prevent it. But overall, is that even where it's available, BHR can be inconsistent. And so if we look at, some of the data here, you can see a table here, and the table really lists different facilities and the hand hygiene compliance in 2018 and 2019. And you can see that selected facilities have been highlighted in red. Before we talk about those particular facilities, I just want to talk about some of our work in these facilities. We selected a few facilities where we wanted to work on alcohol-based hand rub production. So Jinja, Mubende were selected as sites where we felt we could enhance the capacity to produce locally. We trained them on the standard alcohol-based hand rub production based on the WHO's protocol. And we really focused on lab technologists and pharmacists. Pharmacists to oversee the process, and lab technologists to really conduct the mixing and the distribution. What we did was we asked the hospitals to order the ingredients that were needed from the national medical stores. So these are all government hospitals, and they have what is called a vote in the national medical stores. And a hospital would have, for example, a budget from which they can make requests for this. And then all idea was to provide buffer stock in case one component was missing. What we saw, and we started off with Mubende, was when you had alcohol-based hand rub in the facility ended up doing very well in hand hygiene compliance assessments. So in 2018, Mubende had a score of 54%. At this time, Mubende was producing quite a lot of alcohol-based hand rub. But it wasn't just having the alcohol-based, people had to have some training, and all of that had been done as well. However, we see what happens when supplies go down. In 2019, there were staff changes in Mubende, production went down, a lot of new interns coming at the time the assessment was done, and hand hygiene compliance had dropped to 24%. In contrast, in Jinja, and I think this is quite an interesting, some of the staff from Mubende actually moved to Jinja. And in Jinja Hospital, which is on the second line, hand hygiene compliance moved from 20% to 52%, really at the time when Jinja was spiking its production of alcohol. And so we really saw this as a sign that alcohol-based hand rub was actually driving improvements in hand hygiene compliance. Now, health facilities, in terms of facility-based production, facility-based production makes sense if you have a larger hospital. These hospitals are able to order their own supplies from the national medical stores, as I mentioned earlier. They are also able to estimate their consumption rates. And we were able to come to an average of between 80 liters and say 120 liters per month that were needed in the regional referral hospitals. They have pharmacists that can oversee the whole process. So really they have the right technical cadre to support continuity in production. But we got into conversations with CDC, who had been piloting a district-based approach. And it was intriguing to us because with the larger hospitals, you can produce, but your production is limited to one facility. But if you really want to improve infection prevention and control in a wider area, the district is really the unit that we use. And so the district-based production strategy really recommended for smaller health facilities. So you have a centralized centralized production and then distribution. But of course, one of the challenges is that many of the smaller health facilities may not have adequate space for production. So I'm going to give my colleague Maureen an opportunity to talk about the approach we took towards alcohol-based hand rub production.
Thank you, Dr. Lamode. So I'll go straight into the alcohol-based hand rub production requirements at a health facility. He gave us a brief background of the recommendations concerning facility level production and district level production.
Maureen, I'm not sure we can hear you. It sounds like their internet might be a bit disconnected. Oh. Hey, David, do you want to help out here for a second?
Yeah, we're here. What can we help with?
Do you want to talk us through this slide? And when Maureen comes back in, it'd be great to have her jump back in and explain this for us.
Sure. This is David Berendes from CDC, stepping in to pinch hit. So in terms of production requirements at the healthcare facility, the procurement of supplies themselves, the supplies are not all that difficult to or challenging in terms of what's required. You need 100% ethanol, glycerol, distilled water, and hydrogen peroxide. And then in terms of packaging materials, our production was packaging in jerry cans, and then also including 1 liter bottles for the care points for those with the care points to use.
Right. The personnel you will need to produce alcohol-based hand rub will be lab technologists, and mainly these are in charge of the production because they have a background in working with liquids like this. And then you also need a coordinator or someone who is charged with distribution after the production has happened. Usually, it's better that the production unit is close to the distribution center because it's at the distribution center that we perform external and internal quality control checks. You'll also need standard operating procedures and training. The cadre that we just mentioned above will need training using the WHO. What we're using right now is the WHO standard operating procedures and the protocol for alcohol production. So you will need those and approved standard operating procedures. The intervention. So mainly, let's talk about the intervention in Kabarole. We had a partner and district collaboration between CDC, who mainly provided technical capacity and funding, the Infectious Diseases Institute, the International Water and Sanitation Center, that's IRC, and the district health officials together worked on a protocol to guide, implement, and evaluate the project. It was very important that we had the district with us in this collaboration because later, for sustainability purposes and the plan ahead, this is a project that we think that they can carry on with time using their own cadre and their own leadership. The evaluation here was hand hygiene products. We're mainly looking at alcohol-based hand sanitizer and looking at hand washing stations, and then associated compliance at health care facilities within Kabarole district. We had a component to assess hand washing stations, and mainly it was to make sure that these are actually present. If we are going to compare how health workers utilize both, then we had to make sure that that the two options are available to health workers. And in the end, the evaluation is to see which is the better option that the health workers will reach out for the most in improving their hand hygiene compliance. In this intervention, we, as I mentioned earlier, we collaborated with the district health office, and mainly what they did in Kabarole was provide space for the production and distribution unit. The officials of the district performed the external quality control of the already produced alcohol-based hand rub and supported the distribution processes and coordination with health facilities. The monthly evaluation of hand hygiene stations was also done by them working together with our study nurse or the distributing staff. What Infectious Disease Institute mainly contributed to this intervention was to hire a producer, a study nurse to coordinate the project, and of course provide technical capacity with quarterly visits, and also during the baseline, the mid, and the end evaluation of the project. We also procured raw materials for the production and carried them and shipped them over to Kabarole. We have been using the WHO formulation, and I'll mainly briefly discuss what this formulation, the recommended formulation from WHO, entails. As I mentioned earlier, our ingredients include ethanol or absolute alcohol at 96%. We have hydrogen peroxide, glycerol at 98%, and sterile distilled water. The WHO will mainly will give a formulation for a 10-liter preparation, from which producers are able to extract whatever preparation they need, if it's 20 liters or if it's 1 liter. And for 10 liter, I'll discuss the 10-liter preparation. 96% ethanol, you will need 8,333 milliliters. Hydrogen peroxide 3%, of that you will need 417 mils. Glycerol 98%, you will need 145 mils, and then on that you'll top up with distilled water, and you should have 10 liters of alcohol-based hand rub. This is quarantined for 72 hours, after which it is quality controlled. We do 2 types of quality control. After the producer has mixed this together, he'll do an internal quality control and note what percentage it was. It should be between 75 to 85%. And then the external quality control will be done right after quarantine. So just to go through the procedure right again, the alcohol is measured into a jerry can. Now we're talking about the jerry can, the kind of jerry can that you may want to use. You may choose a 10 liter, but in our case, we're using 20 liters. In there, we measured and added hydrogen peroxide to the alcohol. We measured and added glycerol, rinsing with sterile distilled water to ensure all of the viscous solution is added. We top up to the mark, whether it's a 10 liter jerry can or 20 liter. We top it up with sterile distilled water. The cup is immediately recapped to prevent evaporation. Shake gently and or otherwise mix with a paddle, and fill a liquid solution into final containers. Quarantine in a cool, dry place off the ground for 72 hours. And the reason for quarantining is to kill the spores that may have developed during the production. Mainly the hydrogen peroxide is the active ingredient that will kill the spores that may have developed during the production process. This procedure should take an hour. You should have a jerry can per batch. The batch number is noted on every jerry can. And like I said earlier, internal quality control is done within the production unit. Assess alcohol content using the alcohol meter, and the test, as I mentioned earlier, is between 75 to 85%. The goal should be about 85. Quarantining is 72 hours for the reasons of killing the spores that may have come into the solution while during production. External quality control is done by the district health office, in our case in Kabarole, and the procedure is the same as internal quality control. Once we are sure that we have quality controlled alcohol not below 75%, then we are ready to distribute it to the health facilities that are supposed to receive it. Quickly, I'll discuss how we did the alcohol distribution. earlier in the production unit, the last point is to put it into the jerry cans and weigh and quarantine it for 72 hours. Once we are confident in the external quality control, so we'll get the jerry cans to get the quality control jerry cans and the complementary containers, which include the 1 liter bottle, 60 ml bottles. On here, we were sticking stickers with information concerning the alcohol-based hand rub, how it is to be used, its ingredients, the batch number, production, and expiry dates. We plan routes and call the facilities ahead of delivery because we do not want to find nobody at the facility. The distribution routes are usually planned with the support of the district health office. This is one of the ways we involve them during the distribution. We prepare documents, job aids, sign-out sheets, and mainly the job aids will be talking about hand hygiene, what is moments of hand hygiene, because in as much as we are distributing the alcohol-based hand sanitizer to them, they need to know how to use it. So partly what we do is give an on-site mentorship while we deliver the alcohol-based hand sanitizer. So we have infection prevention and control focal persons at each facility, and they receive it, and they are the ones responsible for distributing it to care points. Yeah. So I would like to hand over to David to discuss the evaluation results of the study.
Thanks, Maureen. Sorry for the technical difficulties. We're trying to work through the slides. So I'll introduce briefly the evaluation design, and then I'll let Matt go through the results here. So our evaluation questions here. First, we had two main evaluation questions. One was, is locally produced alcohol-based hand rub acceptable to healthcare staff and patients in these settings as compared with soap and water? And then, does the locally produced alcohol-based hand rub improve hand hygiene practices among healthcare staff compared with soap and water again? So we're trying to compare specifically, we were designing to compare with a hand washing with soap and water alone. The design of the evaluation originally was a crossover design, so we randomized intervention and control healthcare facilities, and then we were going to cross them over after midpoint. We did a baseline assessment. We then would have grouped them into Group A and Group B, 15 facilities in Group A, 15 in Group B, assign them to either an intervention, so getting the hand sanitizer on the top as in Group A, or not getting the hand sanitizer, hand rub as a Group B. Monitor them for a 3-month period, and then assess hand hygiene at midpoint. After midpoint, we then would have crossed them over. So Group A that had hand sanitizer loses it, and Group B that didn't have hand sanitizer gains it at that point. Monitor them again for 3 months, and then conduct an endpoint assessment. So this is the ideal world situation, but of course I say ideal world, and we know that there's always real world considerations. In our case, it was that right after we did our baseline assessment, we found, or there was the beginning cases of Ebola in the Democratic Republic of the Congo, which is close to or with a district that we're working in Uganda, and DRC neighbors Uganda. So Ebola preparedness was in the forefront of everyone's minds, and as part of that, UNICEF and WHO distributed hand sanitizer, specifically the Soraya hand sanitizer, to all of the health facilities within the district where we were working. Those of you thinking about the design will say, great, you just lost your control group. You're right, we did. So we had to sort of do the best with what we could. And so we sort of modified some of our questions and our thoughts, since all of the facilities now had hand sanitizer, to say, okay, can we really figure out whether the locally produced hand sanitizer is as good as the much more expensive Soraya? As Dr. Lamorde alluded to, Soraya in stores to buy it is about $8 to $10 a liter, whereas we know that the production cost of the local hand sanitizer is about $4 to $5 a liter. So our new evaluation questions were, is locally produced hand sanitizer or this hand rub acceptable to healthcare staff and patients in these settings? Again, we can't compare specifically to soap and water because we have sort of lost that control group. Does the locally produced alcohol-based hand rub improve hand hygiene practices? And then again, we have now essentially a before and after intervention where we lost our control group. So we have quite a few limitations we'll discuss at the end, but we can't really attribute our changes necessarily to the intervention itself because there were Ebola awareness and preparedness going on at this time. But we did sort of think about having this as almost a non-inferiority evaluation where we're looking at how does the locally produced hand rub compare to Soraya, because one can argue if it's just as good, then we're willing to produce it locally and use the lower cost option because Soraya is certainly not available throughout Uganda or throughout other low and middle income countries. And so our timeline was in August and November of 2018. We did a baseline. In February of 2019, we started our distribution of the alcohol-based hand rub. In June, 3 months later, we did the midpoint. We did cross over or try to cross over the locally produced hand rub to other facilities while still maintaining all facilities having hand rub. And at this point, that was because we felt it was more important to make sure that facilities had hand hygiene materials for Ebola preparedness than to maintain sort of the study design itself, given the threat of Ebola in DRC. And then we just finished the endpoint evaluation last month, and we're planning a full data dissemination meeting, next steps meeting in January. So this is literally hot off the press data. So I'll let Matt now talk about the methods and get into the results.
Thank you, Mohammed and Maureen and David. This is Matt Logier, also from the CDC in Atlanta. So for the evaluation methods, there were two major methods that I want to talk about today. There were some other methodologies and techniques that we implemented, but today we'll talk about the hand hygiene observations that we did. We carried those out at baseline, midpoint, and at the end point, and they were observing the hand hygiene compliance before patient contact and then also after patient contact. So we kind of have two observations or two data points in which we were observing the hand hygiene. And this was carried out by enumerators that would visit the healthcare facilities and try and be kind of like secret shoppers. They didn't explain that they were there to observe. They were there to clinics or facilities operated to understand better, so that the people ideally weren't 100% aware of that they were being observed for hand hygiene purposes. We also did alcohol-based hand rub quality control. As Maureen mentioned, after the hand rub is produced, it's in quarantine for 72 hours, and then it's kind of independently, we do quality control check. It was done by the district health office just to make sure that it's still meeting the alcohol percentage standards, which is between 75 and 85% alcohol. So when we went out into the field to do the midpoint and the endpoint evaluations, we also did a check of the alcohol concentration just to make sure that, roughly 3 to 4 months after it had been distributed to the field, that it was still maintaining that, meeting the regulations for alcohol percentage. So that was, of course, it wasn't done at baseline because no hand rub existed at baseline, but it was done before distribution and then done 3 or 4 months later in the facility at both the midpoint and endpoint evaluations. So first, looking at the alcohol-based hand rub quality control results, we used an alcohol meter to measure, and the mean alcohol concentration was 78% of all of the alcohol-based hand rub that we tested in the field, and it ranged from 75 to 80%. So still 100% of the alcohol-based hand rub in the field still met the guidelines for usage. Now focusing more on the hand hygiene observations that we observed before and after patient contact. At baseline, we observed hand hygiene practices in 20 healthcare facilities. And at midpoint and endpoint, we did it in all 30 of the healthcare facilities. That was because at baseline, we did not observe the hand hygiene practices in the health center twos, which are the smallest or the kind of dispensary health centers. But we thought that it was important to also evaluate the hand hygiene practices in the smallest health centers, as well as the HC3s and the health center 4s. At baseline, we also observed it at 2 hospitals that were not included in the alcohol-based hand rub study. That's why there were 20. The workers, we observed the hand hygiene practices of a wide variety of healthcare workers. At baseline, it was a total of 44 workers, and you can see the distribution. Most of them were lab technicians, but it also included 8 midwives, 12 nurses, and 7 clinical officers. At midpoint, because we were observed, there were 68 total healthcare workers observed. Again, most of them lab technicians, but also several midwives. Most of them were nurses this time. 22 nurses and 9 clinical officers. And at endpoint, we again observed a higher number of healthcare workers, with 27 nurses being the largest, 20 laboratory technicians, and 15 midwives, and 9 clinical officers. And so we'll look at some of the data, and this is really kind of high-level aggregate data. We're not looking at individual facilities and their hand hygiene practices yet, or we're not looking quite yet at healthcare workers and the differences. But what we want to do is we recorded the hand hygiene both before and after patient contact. And what counted as hand hygiene was if they used alcohol-based hand rub, that was recorded. And as David mentioned, there was the alcohol-based hand rub produced by this locally produced hand rub that we referred to as the IDI hand rub. And then there was also the Soraya hand rub that was distributed by WHO and UNICEF. So we recorded which one was used. Of course, hand washing with soap was also recorded as a hand hygiene compliance. If they donned new gloves before patient contact, we recorded that just in our observations, or we recorded that no hand hygiene practices took place. In order for it to count as compliance, we counted alcohol-based hand rub or hand washing with soap and water as hand hygiene compliant. Donning new gloves was not considered hand hygiene compliant because if there's no disinfectant used, the gloves, of course, can be contaminated, and so it does not count as hand hygiene compliant. Looking at the results here, I'll walk you through this. At the top columns, and I say 3 columns, there's really only 2 columns, but because one of them was 0. But at baseline, the hand hygiene compliance before patient contact was 0% of the time. So this, of all of the observations that we did of all of the healthcare workers, 0% of the time we observed hand hygiene compliance before patient contact at baseline. That increased to, I don't know if I don't think I can see that. Let's see. Okay. That is, you see in the green bar on the top. And then at endpoint, when back several months later, the hand hygiene compliance before patient contact actually decreased back down to 8%. So still higher than at baseline, but we kind of saw an initial increase at the midpoint evaluation, and then followed by a decrease in hand hygiene compliance. And when we look at after patient contact, we see a similar trend, but we see that overall the hand hygiene compliance is much higher. At baseline, 15% of the hand hygiene observations were compliant, and that increased to 62% at the midpoint evaluation that we carried out. And then again, at the endpoint, we saw slightly lower hand hygiene compliance in 42% of the observations, but still much higher than the baseline hand hygiene compliance of 15%. So we see similar trends in general for both before and after, and that we saw a significant increase from baseline to midpoint, and then we saw a decrease from midpoint to endpoint, but still the endpoint hand hygiene compliance was significantly higher than baseline. If we look at this a little bit closer, right here, these are just aggregate, did they perform any hand hygiene? And I want to unpack this a little bit and look more closely at what type of hand hygiene they performed, whether it was using alcohol-based hand rub or using hand washing with soap. So first we'll look at before patient contact. And this is similar data, so you'll notice on the left that at baseline, there was 0% of the time of all of the 208 hand hygiene observations that we had, 0% of the time they performed hand hygiene. At midpoint, it was 22% of the time hand hygiene was performed in some form. We see that most of that was with the alcohol-based hand rub, which is in orange. So we see that 17% of the time hand hygiene was performed at midpoint using alcohol-based hand rub, compared to 5% of the time when hand washing with soap was performed. And then 78% of the time there was no hand hygiene observed. At endpoint, we saw it decrease overall to 8%, which was made up entirely by alcohol-based hand rub hand hygiene compliance at the endpoint. So at the endpoint, we saw higher hand hygiene in general. We didn't see any hand washing with soap before patient contact at the endpoint evaluation. Moving on to looking at after patient contact, at baseline, we saw that 12% of the time healthcare workers were using hand washing with soap. There was a small percentage of times that we observed alcohol-based hand rub, even though neither Soraya nor the locally produced hand rub had been distributed at baseline, but 3% of the time they were using alcohol-based hand rub. It must have been purchased by the individual healthcare workers or by the facility to have that available. At midpoint, we saw a large increase in hand hygiene practices after patient contact, especially among the alcohol-based hand rub. It went all the way up to 55% of the hand hygiene observations were compliant with hand hygiene by using alcohol-based hand rub. And then we see that 7% were performing hand washing with soap at the midpoint. And again, at endpoint, overall, it decreased a little bit, but we still saw that the largest driver of hand hygiene compliance was use of alcohol-based hand rub. 39% of the hand hygiene observations were done with alcohol-based hand rub, whereas only 3% were performing hand washing with soap. So that's a glimpse at some of the preliminary results. As David said, this is hot off the press. We just finished collection of the end line data about 4 or 5 weeks ago, and are still kind of analyzing this data. We are looking into differences across healthcare facility size, whether or not healthcare facility HC2s versus 3s and 4s, were there differences in hand hygiene practices by healthcare facility size, or by the different types of healthcare workers? Were certain workers more likely to perform hand hygiene than others, or to use alcohol-based hand rub than others? We just haven't gotten that far in the data analysis yet. So some of the preliminary conclusions that we've arrived at with this data is that access to alcohol-based hand rub has increased hand hygiene compliance among healthcare workers in Cabarole District. The increases in compliance from baseline to midpoint may have decreased slightly at endpoint. We saw a decrease at the endpoint, and the largest increases were due in large part to an increase in use of alcohol-based hand rub, not an increase in hand washing with soap. While we saw improvements in both hand hygiene before and after patient contact, the hand hygiene before patient contact, even with alcohol-based alcohol-based hand rub still remains low at 22% at midpoint and 8% of the time at endpoint. Some of the strengths and limitations of the project and of the study, we see that the locally sourced production of this waterless and portable and quick to use hand hygiene solution, it's something that's locally produced, and it can sit at each patient care station. It's a small 1 liter bottle that can be moved around the healthcare facility versus a hand washing station, which often is maybe a 20 or 40 liter tank that is much harder to move around. We also saw that just in general, it's feasible. The capacity was built and established in this district to produce and to distribute alcohol-based hand rub, and the training and the capacity of the actual healthcare workers. And so we also were able to monitor hand hygiene compliance in the facility. So there is a capacity that is developed in Makerere district that can possibly be utilized in the western region of Uganda. There are limitations, of course, to the project. Because of the funding that was available, we were distributing alcohol-based hand rub with hired cars, which is a model that's not very sustainable in terms of cost in the long term. It was nice to be able to do this just to test the feasibility of the production and distribution and the impact that it has on hand hygiene compliance. But it's important to look at how we can make distribution more sustainable. So some considerations of trying to integrate the production into the district or national budgets there are still obstacles that exist for integrating production into those district budgets. Some of the raw materials actually are not sold in Uganda through the national medical supply stores. So if you cannot, the healthcare facilities can only purchase products from that national medical stores, and if one of those products is not available, it would be difficult to integrate this entirely into the national system there. Also, in terms of being able to distribute alcohol-based hand rub on the national medical stores trucks that distribute other supplies such as drugs and medical supplies to the facilities, the approval is needed to be able to do that. And so, but that would ultimately help reduce the cost of distribution to not have to hire cars. Also, in general, alcohol-based hand rub is not effective against all pathogens. Norovirus and C. difficile are not killed by hand rub, and so also soiled hands are not necessary. Alcohol-based hand rub is not recommended if your hands are visibly soiled. So hand washing with soap and water still needs to be maintained and promoted, and as well as possibly integrating an alcohol-based hand rub. Hand hygiene before patient contact, it did increase significantly, but again was still poor overall. And then you may have noticed in the picture there was the 20-liter jerry can, a 1-liter pump bottle to put at workstations, and there was also a 60-milliliter personal bottle that we distributed to each healthcare worker in the intervention facilities. We were told by workers that they liked it, but it often was misplaced or was lost by the providers. So it was not seen as a very viable intervention. The cost of those, if they just ended up gone missing or disappeared, it was not very effective. So we want to change the conversation a little bit to sustainability. The project went on for 1 year, and we'll actually be doing a data dissemination of these findings back in Makerere district with the district health office and our partners at IDI and also IRC, and reporting these results back to the healthcare workers and the in-charges from the facilities. But it's important. We also received funding to continue this project for 1 more year in Makerere district, and to work really on integrating it more into the healthcare, into the district health operations. We also received funding to expand it to a neighboring district in Kasese. So in Cabarole District, we hired an ABHR producer, but we're also working towards training 3 district health office staff that are permanent staff to learn how to produce alcohol-based hand rubs so that there's local capacity to do that. Again, the distribution of ABHR to the 30 healthcare facilities for 1 more year. Over this next year, we're trying to transition from hiring vehicles to distribute it through the regular national medical stores vehicles that do quarterly distributions of other medical supplies. Support within from the district. So while we haven't integrated all steps in district office or a partner in the process, so we're just working to transfer more of the project over entirely. I mentioned that this is being expanded to Kasese District, which neighbors Cabarole District, and also Kasese District does border the DRC, and so because of this outbreak, there's a lot of infection prevention and control and Ebola prevention work and preparedness work going on in Kasese District. So just in the last couple months, 2 district health office staff have been trained to produce waste hand rub in Kasese District. The first phase of production was just completed, I believe, last week, and the 72-hour period passed, and so now we have funding, and this is in place to work for the next year. The district health officer in charge of all of the district health activities insisted that we incorporate this into the NMS supply trucks, which is of course more sustainable. So it's nice that in Kasese District, because of the urgency and maybe some of the support that's going on with Ebola preparedness, they're able to, from the beginning, try and make this a more sustainable activity and project in their district. So I think there's a lot that Kasese can learn and that we've learned from our experiences in Cabarole District, and then vice versa, because Kasese is beginning a more integrated and sustainable way. I think a lot of what's going on there, hopefully over this next year, can be translated into Cabarole District. So thank all of our partners, of course, at Infectious Disease Institute in Makerere University in Uganda. Also at IRC-Y for critical partners at the district health office in Cabarole District, and also for the evaluation, we utilize the laboratory in the Fort Portal Regional Referral area. Here at CDC, there were a lot of support from colleagues and technical assistance. So with that, we discussion.
Great. Thank you so much to Mohammed, to Maureen, to David, to Matt. These are fantastic presentations, and I'm sure everyone's very excited to hear about the work that's undergoing in Uganda. We have a number of comments in the chat box. If you'd like to add an additional comment, please feel free to type it in the chat box. Please put all panelists and attendees so that everyone can see your question. And I'll start out with a couple of questions. I'm going to give these to you in bulk here to try and cover as many as we can. If we don't cover your question, I will ask IDI and CDC to look at the questions afterwards. I don't like having leftover questions that get skipped over. So starting with Maureen and Mohammed, a couple of questions for you. Thinking about you mentioned at the very beginning, I think it's really interesting why you started doing this work, because of the changes you were seeing based on locally produced alcohol. Is the alcohol that you produced for your project similar to the locally produced alcohol that was being used prior to this? A few more questions on that. Another group asked also about whether or not substitutes for ingredients are possible within the WHO formula for alcohol-based hand sanitizer. And then Christine Moe asked about if you could speak a bit more about the testing of the quality and the shelf life of the product. And I'll hand it over to you all to cover those.
Thanks a lot, Lindsay. Yes, the first question, yes, it was the same procedure we used for production of alcohol for the health facilities as well as for the district part. The second was the substitutes that we could use. In terms of substitutes, the WHO recommends isopropyl alcohol. However, we didn't have to use that. We always got exactly. I think for the third question, in terms of how we assess for quality, this was with an alcohol meter. I'll ask Maureen to describe the process.
Yes. It is done using an alcohol meter, and it's a buoyant, small device that will just mainly lift off and tell you what percentage of the is. So discuss will really tell you whether it's 75% or 80% at the float. So that is how we assess for it, both at internal quality control and at external quality control.
And I know it came up in the chat. Somebody wanted to know, so the alcohol we produced was 75 to 80% ethanol.
Yes.
Thank you.
Great, thank you. Turning over to Matt and David for a moment. There was a couple people who asked the same question around why you assessed only at the 2 moments of the 5 WHO key moments for hand washing, why you chose the before and after the patient contact versus some of the other opportunities for hand washing.
Yeah, that's a good question. So really within our larger wash and healthcare facilities project that's working, we as a group, and really Maggie Pearson and Victoria Chernice have led on this in terms of just making a decision around what's feasible and practical versus the ideal, and finding the 5 moments would be great to be able to do. However, it's in a lot of these facilities, some of those moments may not apply if there are inpatients, and sort of in talking with other colleagues who work in the Washington healthcare facilities. To start with, again, this is, we went to the 5 moments for a lot of these cases, but I think that before and after patient contact, 2, kind of universally understood critical areas to look at that are feasible to look at in all cases, whether it's an outpatient or inpatient that you're dealing with.
Great, thank you, David. So a couple other questions. There was an interest in understanding what the access to soap and water was prior to the start of the intervention. Did you collect that information?
Yeah, we did at baseline. We did kind of a detailed assessment of every single hand washing station area, and actually patient care area, and whether or not there is a hand washing facility available or not. Well, sorry, also
Hi, all. Apologies. I dropped off there.
What could you define as before attend and cannot only and dealing with lines, and so the 5 moments of hand hygiene as recommended by WHO is a stepwise procedure for a health worker that will give them all the opportunities for them to hand rub.
So I think another big question is the total cost of the product,
Yes,
isn't it? I think that's an important question. And of course, when you try to set up a program like this, there's always the overhead cost in terms of setting up the facility for the production. But if you're just looking at the costs of the mixing and if you take away labor costs, so for example, if government officials in health facilities do the mixing themselves, the cost comes quite low. I mean, it can be as low as $2. I think if you add some labor costs, maybe going up to $4. But that would be around 50%. $4 would be about 50% of what we would get for commercial hand rub. If you're just looking at the cost of the ingredients for mixing, it can go even below $2. So we see this as an important opportunity. One of the conversation points is whether we can get this produced centrally for the country. And importantly, the National Medical Stores does purchase commercial alcohol to some quantity. And you can think about it, if they were to switch to a blending option with the same budget they have, they may be able to double, potentially even triple the amount of alcohol that can be distributed to health facilities.
And another interesting question was about dispensers. Why the dispensers were not included? Mainly here, dispensers are commercial, and they probably will be selling their own product for hand rub. So we felt confident that the people that need and will have benefit of the alcohol-based hand rub will be the health workers who are dealing with patients.
One final clarification, just that I want to make, because someone asked about the observations, and one thing we may not have noted was that when we did observations of healthcare workers, we looked at 5 patient contacts per healthcare worker before and after, and so that's why those N's were larger than the number of healthcare workers, is because those total N of observations should roughly be 5 times the number of healthcare workers observed. And we did count also when we were observing patient contact, if someone saw a patient and then cleaned their hands and then immediately saw a patient afterwards, that cleaning their hands would count as an after for the previous patient and a before for the current patient, as long as there wasn't any contact with another surface or other material in between.
Thank you so much, David. I do want to quickly, before we close here, cover a question that Martin Wasisi has asked. Make sure that we're all on the same page on this. Is it possible that continuous use of alcohol-based hand sanitizer can result in AMR? And I open that to anyone to answer
that. Good question. I think that currently the microbes that we're seeing, and Mohammed, please jump in as well, but I think that currently the microbes we're seeing, we're not seeing a ton of resistance yet to ethanol or alcohol, but we are starting a little bit. I've seen a few studies kind of hinting at this, at changes in the microbes themselves. But that is, of course, something, especially in healthcare settings, to continue to monitor. So I think that's a great point, Martin.
Yes, I mean, I think at this time we see it as actually an opportunity to prevent, the rapid emergence of AMR that would happen if you didn't use it at all. But yes, you want to look specifically at the microbes themselves and see if there's a pattern that is.
So a bit of a double-edged sword there, Mohammed. That's a great point. Thank you. Well, thank you all for joining us. It is a couple minutes past. I'm sorry I lost my internet there for a second, so I am sure the conversation continued on well. We will be sharing the recording of this. I will send out a YouTube link if you'd like to share it with your colleagues. And I will ask Mohammed and Maureen and David and Matt to look at the questions, and if anything was not answered, we'll make sure we get a response to that we can send out by email. So thank you again all for joining. We so appreciate CDC and IDI, and we're excited to see where the further analyses go. Thank you again.